In this study, we trained a deep learning model to segment lymph nodes that are positive for tumor metastasis from oral cavity cancer patients. CT scans from 107 oral cavity cancer patients with pathologically confirmed lymph node metastasis were collected. For each patient, ground truth segmentations for positive lymph nodes were manually performed on pre-surgical CT scans. The segmented CT scans were then randomly assigned into a training set with 85 scans and a test set with 22 scans. Five-fold cross-validation was then performed on the training set to train 5 separate three-dimensional residual nets. The 22 scans in the test set were then evaluated for each of the 5 models to generate 5 separate predictions for voxels positive for lymph node metastasis. A staple algorithm was then used on the 5 predictions to generate a consensus mask as the final prediction. To quantitatively measure the performance of this method, the dice coefficient between the consensus mask and ground truth segmentation was calculated for each of the cases in the test set, resulting in a median dice coefficient of 0.33. As seen in the histogram on the left, there was a range of dice coefficients from 0 to 0.73. Interestingly, a previous study from our group where we trained an autosegmenter for lymph node metastasis in oropharyngeal cancer patients resulted in a median dice coefficient above 0.9. However, we noticed that in the oropharyngeal lymph node metastasis, our dataset had patients with less than 3 lymph nodes with large metastatic lymph node volumes, as opposed to the oral cavity patients that had lymph node metastases which were much more heterogeneous in both size and number. To determine how our oral cavity model performed on cases comparable to our oropharyngeal study, we calculated the median dice coefficient on patients which had a small number of large lymph node metastases to patients that had a large number of small lymph node metastases. As seen in the stacked histograms, the predictions for patients with a small number of large lymph nodes had a much higher dice coefficient of 0.65 compared to the predictions of the other patients, which had a median dice coefficient of 0.28. In conclusion, to our knowledge, this is the first study to train an autosegmenter for lymph node metastasis in oral cavity cancer patients. While our model showed a clear predilection for cases with a small number of large lymph nodes, we believe that the model performance can be improved by increasing the patient cohort size and optimizing the deep learning architecture to account for the heterogeneity in the metastatic lymph nodes of oral cavity cancer patients.